So I hope you all brought your seatbelts because this is going to be a wild ride today. We all, I think, share, many of you in the room are here because you share this goal of having an improved understanding of the effects of medical products so that the healthcare community, patients, providers, regulators, others, can more accurately identify and evaluate risks and opportunities to improve patient care. Now that's a kind of lofty goal. It's up there at the top of the mountain. And it's not without support or evidence today to work from. We have a wealth of evidence. In fact, we have preclinical toxicology, clinical trial results, spontaneous drug-reported data, prospective epidemiological studies. We have lots of things that we use today to try to help us understand those effects of medical products. But we also have, over the last couple of decades, a new opportunity that simply didn't exist long ago. The presence and availability increasingly of observational healthcare data, such as administrative claims and electronic health records data, that allow us to begin to study population-level effects of products in real-world settings, something we simply didn't have the opportunity to do, except in very narrow, selected environments until fairly recently. Coupling that with advances in statistical methods, epidemiological understanding, computing power, a whole variety of factors that have enabled us to move forward collectively over the last years in understanding how to leverage that data. So these first symposium that we held in 2009, it's kind of remarkable, it doesn't seem that long ago, but we really just said, gee, we're getting started as another player with all of you in trying to tackle this problem. And we had some simple questions to start out with. Can observational data be systematically explored to identify risks of medical products? How much can we learn in a finite amount of time, and how reliable might the evidence be that can be generated from these observational data? I think that question's maybe a little less in question today, but the evidence behind it is still not strong. 2011, in our second symposium last year, our initial experimental results demonstrated that you could begin to apply some of the epidemiologic methods and statistical methods that all of you have been developing over the years in a way that was feasible and informative, but certainly not yet definitive. And the sort of mixed results, there were some puzzlements in the results that we produced in the first round of work that needed to be answered. And the experiments, the design, wasn't sufficient to allow us to answer those. I'm going to talk more about that on the next slide. So some of you will remember, some of you may have seen in the readings, the first set of experiments that we did, we started out with 10 data sources, several commercially available data sets, the same ones that we used in the next round of experiments, and a variety of distributed partner data sets at academic institutions, healthcare payers, and others that included both claims and EHR examples, and as Tom mentioned, about 200 million lives of data. We also developed a standardized set of implementations of some of the methods, including epidemiological designs and statistical approaches adapted for longitudinal data that might have been useful. We tried to cast a very broad net, all the different ways that you could look. And for each of those methods, a variety of variations of them, for a total of over 1,000 different analytical methods that we had at our disposal. And by putting that data into a common data model, the CDM as we lovingly call it with standardized terminologies and vocabularies consistent with those that are evolving in our national health infrastructure, we are able to apply all of those variations of methods to all of these databases and examine the outcomes for what we came to understand was a fairly small subset or small sample of positive and negative controls. So this grid just has down the left-hand column a listing of the drugs that we examined in the first set of work. Across the top, of outcomes. Across the top, the different drugs that we examined. The red cells represent the 9 positive controls that we worked from, and the blue cells, the 44 negative controls. And what I mean by a positive or negative control is we needed a way to understand, was this method doing what we thought it was doing? We needed to know, should it find an association between the drug and the outcome, or should it not? So for the positive controls, those 9 examples, presumably every time we would like the method to say, yes, this is an associated relationship. And for the 44 negative controls, we'd like it to never say that. Unfortunately, life is not so good. And in fact, some of you may recall that there were examples of wonderful things like ACE inhibitors indeed caused angioedema. It was a fairly reliable finding across a variety of databases, a variety of methods, and a variety of variations. Others were a little more puzzling. Antibiotics and renal failure appeared to be associated frequently. And that really was the foundation for our sort of jumping off point for the next set of work, where an expanded set of experiments, and I'll describe the way that they're expanded in just a moment, have yielded what I think are a little more understandable and implementable results, and helped us start to build some practical insights into how we might build a risk identification system. And as sort of an offshoot almost, as we were looking at the results of that, gained some insights into things that we need to think about as we try to interpret individual study results as well. So obviously this is just a step along the journey. You know, the analogy of the mountain climb you might think about in the last year's work. We found a few really big crevasses that we were going to have to get over, and we found a couple of big glacier fields that looked a little scary. This year we've got a few pythons in place and some ropes strung, and maybe have an opportunity to get a little bit higher up on the next climb. So what we did, based on the findings from last year, very similar approach. Started out with a set of data sets. In this case, we restricted the work in terms of not as many distributed partners, but 4 commercially available data sets from Thomson Market Scan and one from General Electric, as well as a subset of distributed partners. And we were fortunate to be able to collaborate with the EU ADR network, and I'll describe that in a moment, to leverage the availability of data for that project as well. We also believed we needed to have simulated data. And the reason we needed simulated data, I'm going to spend a few minutes describing how we did that in a moment, is that in order to determine whether these methods are accurately and precisely identifying the relative risks that were expected, you needed to know what the relative risk was, which is virtually impossible in observational data. So there are many approaches to that, and we'll describe the approach that we took to creating simulated data that we could use to inject signal, to insert signal for a drug outcome relationship at a known strength and a known timing. So the variety of data sets, again, expressed in the common data model. And we took the same suite of method implementations, enhanced a number of the methods, along with collaboration from many of you here in the room, including the multivariate self-controlled case series method, increased the number of parameters, the number of options, the number of variants on methods for a variety of the methods, and as well as applying existing tools. So the biggest difference, perhaps, in the work this round was that we dramatically expanded the positive and negative controls from 44 and 9 to 234 and 165. And I'm going to talk about that in some detail in just a moment, as well as taking advantage of the work done in EU ADR to choose drug outcome pairs. Variety of other work that we're not going to be talking about as much here today, some of which is represented on the posters, including, for example, approaches to try to improve the health outcomes of interest definitions, some explorations of false positives, some very nice work been done to understand why did you get some of these crazy results when you get some of these crazy results. And we also added during the course of the work a study, which I'll lay the foundation for briefly, that we called EDDI, which was intended to give us insight into how do practicing epidemiologists make design decisions. What do they look at? What are the parameters? What's the distribution of design decisions that folks make? As I said, the core difference between the last set of experiments and this set of experiments that we'll be describing today are the number of positive and negative controls and the level of confidence that we can assert about those positive and negative controls being truly positive or negative. So in order to do that, we did a couple of things. First, we focused on just 4 outcomes and tried to be exhaustive about identifying the drugs that we could identify as being positive controls or negative controls for that outcome. So that let us understand better, for example, for acute liver injury, not just one or two drugs that might be involved, but as many drugs as we could possibly identify that we were sure did cause liver injury or did not cause liver injury. So really trying to sort of nail down, if you will, every potential example that we could. So in order to do this, the criteria that we employed, and we worked very long and hard and consulted many of you and looked for as much input as we could into how to make this as strong and as much confidence as we possibly could, criteria for the positive and negative controls. So in order for a drug to qualify as a positive control, a drug that causes the outcome, three criteria had to all be satisfied. First, that event, that outcome, had to be listed for that drug in a boxed warning or the warnings and precautions section of an active FDA structured product label. So considered process happened, added to the label. We understand completely that there's a whole variety of issues that go into that, class effects, a whole variety of things, but it's a starting point. It also had to be listed as a causative agent in Tisdale's text, drug-induced diseases. So those two sources had to be satisfied. And then, thanks to the hard work of lots of dedicated students, thanks, Brom, and others, a detailed literature review was done, and you could not have any study found that refuted the evidence of effect. In other words, there could be no published study which said this drug does not cause that outcome that was adequately powered to assert that. And obviously you could have weakly powered studies that found no effect, and we tried to tease those out. So all three criteria, FDA label, Tisdale, no literature evidence that would be against, if you will, that drug causing that effect. So typical examples of, out of those 81 drugs that are positive controls for liver injury, isoniazid, out of those 24 drugs for acute renal failure, ibuprofen, and so on. Nothing too surprising there. Similarly, and in a parallel way, for the negative controls, we required three things: that the event not be listed anywhere in a structured product label. There could be no mention of this outcome for this drug in the structured product label. The drug could not be listed as a causative agent in Tisdale, and there could be not one paper in the literature that suggested an association. So what we were trying to do is get as clean a set of positive controls where hard to believe that they're not associated, and negative controls, because these are our test probes, our ground truth, how we're going to examine whether the methods produce the results we expect. These are the results that we expect to the best of our ability. And this was a sort of hard-fought battle, I think it's fair to say, trying to come up with as strong a way and as practical and pragmatic a way as we could of having this set. And this is going to be critical because this is essentially the way that we test. These are the probes, the specific outcomes that we use to test each of the methods and say, did we get the right result or the wrong result based on the truth of these positive controls and negative controls. And the negative controls, similarly, are not surprising things. Upper GI bleeding and pioglitazone, for example, or acute myocardial infarction and clindamycin. The data sets that we used are the same core data sets that we worked with last year. And I'll reference it in your packet. There is a lovely orange sheet and that has the details about these data sets. I shouldn't say the details, but a high-level description of these data sets. And you may find this and these other sheets useful as we go along. You'll see a lot of graphs, a lot of pictures, a lot of diagrams, and it will say something like MSLR. And you're going to go, what in the heck is that? By the end of the day, you'll have them all down. But you might find it helpful to look at these and say, oh, okay, that's the Medicaid data set, or oh, yeah, that's a commercial claims data set, or whatever. So these reference sheets that you find are intended to be that sort of crutch for all of us as we work our way through these data to be able to just look back and say, oh, what was that method that's got the funny abbreviation that we use, so that you hopefully don't get lost. Similarly, The rainbow colored handout, it's actually got red and green, list all of the positive controls, negative controls by outcome if you want to just be able to browse through and see which drugs were included in those. In particular, when you see graphs that pop up and just have a list of drug names, you can actually read them on here versus on the screen, even though we tried to get big screens and things. So fairly, most of the folks in this room are probably familiar with these data sets. GE centricity aggregated from electronic health record data in an ambulatory setting. The market scan lab database, or MSLR, bringing in some laboratory results along with claims data, and then a Medicaid, Medicare, and commercial claims data set with the sizes that you see listed there. We're also really fortunate in a variety of ways that people in the rest of the world are working on this problem as well. As I just described, we set out and chose, as part of this work, about 400 test cases, positive controls and negative controls, across 4 health outcomes of interest, and the 5 databases that I just described. And those are the results that we're going to spend most of the day today describing. But we're fortunate that EU ADR, almost at the same time, was taking a very similar approach and had defined on the bottom left 94 test cases with up to 5 positives or negatives for each of 10 health outcomes of interest, done completely independently of the work that I just described, their own standards and approaches for choosing those. And 6 databases from the European Union, 3 general practice databases, 1 regional claims database, some inpatient and drugs claim data, and 1 national health registry. And that work has been completed, and results are in press, and I think you'll find them very interesting when you get a chance to review them. Well, and so we're just very fortunate that we were working at the same time, and that's part of the advantage of all of us working in this field. There's lots of great people working at the same time. We're able to leverage and build off of each other's work. And so we were able to take the 94 test cases that EU ADR developed independently of OMOP and apply them to the 5 data sets that are available in the OMOP core laboratory. And you'll see some of those results today presented as a validation, as another way, trying to be broader, independent set of outcomes, and we'll let you judge for yourself how that plays out. And then we're also working to take the 399 test cases that OMOP developed using the 4 health outcomes of interest definitions that we developed and apply them to the EU ADR databases. And hopefully we'll be able to get those results soon and see whether we're able to replicate this rather grand experiment in some ways in a completely independent data set, as well as replicating the experiments from EU ADR in the OMOP data sets. I just want to take a moment to mention, because it is central to the work we've done, the analytic data model, or the common data model, which builds a fairly simple data model, builds on national standards. And the beauty of this, again, is it's what enables us to have common implementation of methods across many, many data sets. And so you're running literally the same code on each of these data sets, reducing our chance for error, slip-ups, mistakes in implementation by doing the work up front to normalize the way that the data are represented. And that allows us to do these thousands of different variants of the methods across all of these data sets. We've been evolving that data model. There's some posters that you might look at today that describe this a little bit more. Your USB thumb drives have a detailed description of the common data model for those of you who love pain and punishment and would like to review that, or you can look at them online. But I mention this mainly just to remind people how central this standardized approach and the common data model are to enabling these experiments to happen. Running the EU ADR methods, for example, against the OMOP data sets really just meant we had to modify the definitions of the health outcomes of interest and so on, but we didn't have to rewrite the code, in essence, in order to implement that experiment. The vast majority of the work that we've done and the vast preponderance of the results that you're going to hear today are driven off of those observational data sets, EU ADR, those OMOP central data sets that I talked about. But as many of you will recognize, if you're trying to characterize the performance of a method, one of the things that you often need is you need to know truth. What is the relative risk, or what is the timing of an outcome? And there's many approaches that people have suggested and tried and implemented, in fact, to create simulated data sets that they can use to test these kind of methods. So I'm going to spend just a couple minutes, because there's no place else to do it, describing how we did that, so that you have a little bit of basis when you see that data presented later on. And there's a poster, I think, that describes that in greater detail out in the hall if you'd like to learn more, and there's a couple of publications that comment a bit on it. But we start out by generating a population of patients based on the age and gender distribution that we would like. Now, one of the things that we did, because there's always this debate about, do you start with real data and add signal into it? Well, then you don't understand necessarily the characteristics of there's all kinds of issues you can get into with that. If it's completely synthetic data, is it sort of realistic enough to reflect some of the biases and so on that exist in real data? It's hard to make a real good simulated data set. So the approach that we took to try to do that is we took real data sets and derived marginal statistics from those data sets. And the example data I'll show you here in a minute is from this MSLR database, and apply them within the simulation model. So pretty simple thing to do to say, well, we want ages to be distributed as they are in the database. So you sample from a distribution of ages that's similar to the database, and lo and behold, you get age and gender distributions that look a lot like the real database. On these graphs, for example, the blue bar represents the simulated data, and the real data is represented by the green bars. And we got a nice match across genders and ages to this particular data set. So we analyzed MSLR to understand its structure and characteristics, age distributions and so on, implement that in the simulated data, and sure enough, the populations look similar at that level. So the next step are to create conditions. What diseases does that population have? And again, turning to the real data, we know from the MSLR database the probability that a 50-year-old male will have diabetes, and so we will assign the 50-year-old males in our simulated population diabetes at the same rate by sampling from a distribution, so that this will all add up nicely at the end for simulated patients. And then additionally, from the real data, we know that patients who have disease X may well develop disease Y. So we know the probability that a 50-year-old male with diabetes will then subsequently have a myocardial infarction. So we use that probability to add additional conditions into the simulated patient to build up the problem list, if you will, over time for these individual patients. And this graph just illustrates one way to look at, are you getting that right? Across the horizontal axis, the percentages listed as decimal form of the patients in the simulated data who have the condition. On the vertical axis, the percentage of patients in the real data that have the condition. And each point here, each blue dot, represents one disease, renal failure, myocardial infarction. And as you can see, matches up marginally with the marginal statistics level pretty well with the real data. So once you've added in the conditions, the next thing we do is we add in drugs. And this sequence is very important. From the real world data, we know the probability that that 50-year-old male with diabetes will be dispensed a prescription for, say, metformin. And so we use that probability to add metformin exposure to those simulated patients. So now we have drugs that got there driven by the disease, but there's never a disease driven by the drug from the real data yet. So it's just that one direction. And again, similar graph comes out fairly well. The distribution of drugs across the whole population, where this is just saying one of these dots is metformin, for example, and it turns out that they match fairly well with the populations in the two data sets. So the last step, already commented on that, the last step then is to inject signals of known causal effects. So in other words, say for the patients who got exposed to a drug, did they then subsequently develop the disease? And this is the critical step, because this is going to let us measure when we apply statistical methods to these data, was the relative risk that the statistical method produced the right one, the one we put in? Was the timing 30-day windows, 60-day windows, what we put in? So just to be concrete, if there were a particular drug exposure like Brussels sprouts, to somebody in the population, and we could insert a signal that said 22% of the people who get Brussels sprouts have hair loss, and then we can look and see if indeed the statistical method said 22% increased risk of hair loss due to Brussels sprouts. So this was I spent a lot of time on this relative to some of the other things, and you'll see those scattered throughout the day, bits of data that we derive from this in order to, particularly where we're looking at how well can we hit the relative risk, how well can we hit the timing. So at the end of the day, we think this model guarantees that the drug exposures are independent of future conditions, but conditional on past conditions, which allows us to really capture, we hope, a lot of the confounding that exists and biases that exist in real data sets and still know the truth of the relative risk and the timing. The last bit of kind of materials and methods that I want to mention is we constructed a survey online, epidemiology design, decision, inventory, and evaluation, EDI, because we like to name everything. And basically this was an online survey where we reached out pretty broadly and aggressively. Some of you probably got tired of being beat over the head by emails and phone calls, where we tried to essentially identify what do practicing epidemiologists do when they make design decisions about particular studies. And so this is an online survey. We captured some characteristics of the respondents that we thought might be relevant to understanding their response. And then we presented each of those respondents with a number of drug outcome pairs and a series of design choices that they might be faced with in setting up a real study. And so we really tried to capture here from a broad audience the choices and some of the classifications and characterizations that they might use in practice to inform some of the experimental work. In other words, we could look at the distribution of what did people say they would do as a study design, what kind of time window did they choose, and so on. And there's a very rich set of data to be mined there, and you're just going to see a few things here and there throughout the day today that drew on the EDI results to help inform the direction or process that we went through. So to kind of round out the materials and methods, I'm going to hand over the podium to Paul Stang from Janssen Research and Development. Thanks very much for your attention. Paul's going to review these study designs and the OMOP implementations, and then we'll get to the real good stuff.